Okay, good afternoon once again. Please, we will be starting the process. The topic of discussions on this webinar today is sudden cardiac death. I will be following this particular outlines: the introduction, the epidemiology, the causes of sudden cardiac death, the risk stratification tools, strategies to reduce risk of sudden cardiac deaths, recommendation for evaluations of risk of sudden cardiac deaths, and we now conclude.
So, what is sudden cardiac death? I'm sure everybody has always wondered, we've heard of that statement, sudden cardiac death. So, what is sudden cardiac death?
Now, sudden cardiac death is defined as an unexpected death that occurs within 1 hour of onset of symptoms or within 24 hours of being seen alive and well, and it is presumably due to cardiac arrhythmias or hemodynamic catastrophes. Okay. Now, this sudden cardiac death could be the one that is witnessed or the one that is not witnessed. For epidemiological and clinical reasons, the sudden nature of the death is put at 1 hour, usually from the onset of those clinical symptoms that erupts the terminal symptoms and the cardiac arrest itself.
So what's the incidence, the epidemiology?
Okay. Before we reach that, well, we should know that cardiac arrest and sudden cardiac death itself entails the sudden cessation of cardiac activities with hemodynamic compromise. However, if there is an intervention such as defibrillation or cardiopulmonary resuscitations that restore back the circulation, the event is about to have sudden cardiac death. But however, if it is uncorrected, the sudden cardiac arrest event will now lead to death and is then referred to as sudden cardiac death. Now, to satisfy the clinical and scientific, legal and social considerations, there are 4 temporal components to definition of sudden cardiac death. And there could be a prodrome of symptoms, the onset of the terminal event, the cardiac arrest itself, and the process of the biological death. But however, it's not all patients that have the prodromal symptoms. Some will just have the onset of the terminal event that entails the loss of consciousness, the following development of arrhythmias, they develop hypertension, chest pain, dizziness, and they progress almost immediately to cardiac arrest. While some takes minutes to an hour before they progress from the onset of the terminal illness to the cardiac arrest itself. This will now be followed by the process of biological death itself, usually result from failure of resuscitations or when there is failure of electrical or mechanical or the CNS functions following the initial resuscitation of the patient. Now, the 2 most relevant clinical factors that one should consider when you are defining a sudden cardiac death is the onset of the terminal event and the clinical arrest itself. While for the legal and social consideration, it focuses mainly on the time of the biological death.
So now, in the epidemiology, how was the incidence and how common is the sudden cardiac death in our society?
Now, the sudden cardiac deaths accounted for around 50,000 death cases in the US per annum, and it's accounted for approximately 50% of the cardiac deaths. However, the incidence increases with age, especially from the age of 35 and above. It predominates in males, and this could be the first presentations in 25% of cases. In our terrain in Nigeria, there are various reports on the incidence of cardiac death, but they are, however, an hospital-based prevalence, not a generalized incident for the whole country. Now, if you look at this graph, you notice that looking at the sex and the age, as I mentioned earlier, the prevalence increases with age, and it tends to be it's more commoner. It's more commoner in in the male sex. Now, if you also look at this particular diagram, you realize that the incidences in people that are less than 30 years of age, the adolescents and the younger adults is 1 in 100,000, and usually result from these listed causes like myocarditis, hypertrophic cardiomyopathy, the long and short QT syndrome, etc. However, for people that are 35 years and above, it indicates about 1 in 500 to 1,000. And this increases in people that has an advanced heart failure. Usually, you can see it 1 occurrence in 4 in those people that has an advanced heart failure.
So is there a way we can classify the causes of sudden cardiac death?
Now, the causes of sudden cardiac death could be structural, and it could be because of primary electrical abnormalities of the heart. And the structural causes include the ischemic heart disease, which is the #1 cause of sudden cardiac death, followed by non-ischemic cardiomyopathy. It could be as a result of hypertrophic cardiomyopathy. It could also result from arrhythmogenic right ventricular cardiomyopathy, valvular disease, congenital heart disease, and anomalous coronary artery origins. For the channelopathies, the congenital long QT syndrome is one of the causes. Now, if you are seeing on our conventional ECG, by the time you are seeing a long QT on an ECG, the first thing you want to do is to try and see if you can exclude the acquired causes like electrolyte, hypocalcemia, hypokalemia. If there is any drug that patient is taking that is producing them to long QT syndrome. In the absence of this, probably we are dealing with a congenital long QT syndromes. However, the value varies for the sexes. For male, it ranges from 350 to 450 milliseconds. When it's above 450, we will describe that as a long QT syndrome. Now, for the short QT syndrome, when they have a value that is less than 320 on the male sex, and we have 330 on the females, that was described as a short Q syndrome. We have the Brugada, that has the typical ECG changes that we are going to describe below as we move on. We have the catecholaminergic pulmonary ventricular tachycardia. Usually, the results from increased catecholamine, probably during emotion, stress, or exercise. And what you see is they tend to have pulmonary ventricular tachycardia during that episode. Usually, when you do their conventional ECG, it tends to be a normal ECG, unless when they have that particular episode. Now, the risk factors for development of sudden cardiac death are somebody that have had a prior history of ventricular tachyarrhythmias, post-myocardial infarctions, people that has low ejection fraction or they have congestive heart failure, family history of sudden cardiac death, myocarditis, and non-cardiac causes like pulmonary embolisms.
So I'm sure now people will be wondering, how can we identify people that are at risk of a sudden cardiac death? So please, can you shed more light on that?
Yes, the risk stratification of patients that we are suspecting as a sudden cardiac death start from the history. From the history, you can have a good idea about the likely causes or the risk of development of sudden cardiac death. When you have seen a patient that has clusters of cardiovascular risk factors for coronary artery disease, somebody that has a family history of sudden cardiac death, family history of coronary arterial disease, and unexplained syncope in a non-patient that has a structural disease, history of heart failure, and survival of cardiac arrest. All these will be a pointer that this particular patient that we are dealing with are at risk of sudden cardiac death. Now, we can also use the conventional ECGs. Changes on ECGs will give us a good idea about patients that will have risk factor for sudden cardiac death. Now, the presence of pathological key wave or dynamic ST changes on ECG, it could be a pointer to an old MI, myocardial infarction, and ongoing myocardial infarctions. When you have a prolonged QT prolongation of fragmented QRS complex, what this implies is that with the widening QRS complex, the depolarization of the ventricle is prolonged, and this made them to be prone to abnormal arrhythmias that predispose them to risk of sudden cardiac death. Prolonged QT intervals that predispose them to risk of pulmonary ventricular tachycardias, left bronchial branch blocks, and left ventricular hypertrophy. Because of the micro ischemia that they have risk of increased arrhythmias. Ventricular tachyarrhythmias, if you see frequent pulmonoventricular complexes, post-myocardial infarction, especially when they are repetitive, all this produce the risk of sudden cardiac death and total mortality during the follow-up period. Now, from the ECG as well, as I said earlier, when you pick an ECG and the corrected rate QTC interval is prolonged, meaning that for a male is more than 460 milliseconds. Well, sorry, for a male is more than 450 milliseconds. For a female is more than 460 milliseconds. When you see this, you will be having an idea that probably this patient is having a prolonged QT. For the short ones, usually 320 and 330 for male and female respectively. For the Bulgaria syndrome, typically they have this cuff-shaped ST segment elevation in V1 to V3 with an accompanying T-wave inversion. There could be different types, and the trigger varies from emotions, stress, and some even can occur during sleep. Now, the arrhythmogenic right ventricular cardiomyopathies, this is usually as a result of the fatty depositions on the ventricular, especially on the right ventricles. And this can predispose patients to the development of ventricular tachyarrhythmia. Parkinson-White, which is when there's an ancestral pathway that you see as certain PR interval or ECG, which can also predispose patient to development of arrhythmias. Now, looking at this ECG, these are different morphologies of PRS complexes that can predispose patients to the development of ventricular tachyarrhythmias. Patient can present with chest pain, palpitations, sudden collapse, and it can lead to death. If you look at this ECG, the first one, you can see the KRS complex is widened, meaning there is a delayed ventricular depolarization, and this can predispose patient to the risk of development of ventricular tachyarrhythmias. Now, this is an ECG parameters that we can use to predict patient at risk of sudden cardiac arrest or sudden cardiac death. And the patient that is coming with an heart rate of more than 70 beats per minute, patient that has the QRS to T angle that is more than 90 degree, left ventricular hypertrophy, corrected QT interval that is more than 450 for males or 460 for females. When you have the T peak and T hands abnormality, or with a period of more than 89 milliseconds, or when you have a delay KRS transitions, all these will predispose patients to development of sudden cardiac death. Now, this is a graph showing a typical example of Bulgaria syndrome type 1, when you see an ST segment elevations, usually involving V1 to V2, at times can involve the V3, usually more than equal to 2 mm, with a negative T wave on the same leads. It's an high risk that can predispose patients to risk of syncope as a result of ventricular tachyarrhythmias, and there will be different triggers, as I mentioned earlier: fever, during exercise, some can occur during sleeps, and in addressing this sort of patients, electrolyte abnormalities and medication of such a patient, we have to be looked into. Now, for the long QT interval, this is a pictorial diagram. Usually, the rule of thumb is when you are picking an ECG, when we are seeing the QT interval on the ECG, usually it's supposed to be less than the preceding hour interval. Now, this will give you an idea that probably you are dealing with a normal QTC period. But by the time you are seeing the corrected QT interval of more than 460 per millisecond, it's a pointer to a long QT. In such an instance, you want to try and rule out the likely reversible causes. And anybody that has a QT interval of more than equal to 480 milliseconds on a repeated ECG, it's pathological. And if you have a QT interval of 460 to 480 milliseconds that are accompanied by syncope, it's also concerning, and it's something you have to probably assess the patient and assess the need for an implantable cardiovascular defibrillator in such a patient. Once you see something similar to what I described, you want to try and evaluate further the patient. You take the family history to be sure that there is no history of sudden cardiac death in such a patient, and such a patient can be assisted once the risk is there. The consideration for an implantable cardiovascular defibrillator in this instance will be considered. This is short QT syndrome. As I said earlier, the corrected QTc is usually less than 30 milliseconds is diagnostics. But if it's between 330 to 360 milliseconds, other supporting features such as syncope, previous history of cardiac arrest, or families of sudden cardiac death are required to say the patient has a short QT syndrome. Now, this is a pictorial picture showing an early repolarization, which is the high-risk phenotype. What you see usually is the J point elevation of more than equal to 1 AM is accompanied by an horizontal, accompanied by an horizontal or descending S segment elevation in the inferior lobes. And usually it's an high-risk ECG findings, different from the typical benign early repolarizations that is accompanied by an early S segment elevations. This usually we need to be corrected with the symptoms. Family history, we need to be assessed, and further evaluation for arrhythmias we have to be explored in such a patient. The arrhythmogenic right ventricular tachycardia, which, as mentioned earlier, is because of fibrofractive depositions on the ventricular wall, usually on the right side. But the typical thing that you see on the ECG of the patient is the T wave inversions in V1 to V3, accompanied by an epsilon wave. The epsilon wave is as a result of delayed repolarizations in the patient. Now, diagnosis is based on international task force criteria, accompanied by the echo test and cardiac MRI, where to confirm the diagnosis. In such a patient, exercise restrictions is mandatory, and you need to stratify for possible ICD implantation in such a patient. Now, pre-excitation syndrome, which is a non-risk for sudden cardiac death, is characterized on ECG by a short PR interval with slurring of the initial limbs of the QRS complex. It is high risk if the accessory pathway conducts faster. And what you see on the electrophysiology study is the shortest pre-excited RI intervals will be less than equal to 250 milliseconds those patients that have atrial fibrillations, or if the accessory pathway effective refractive period is less than equal to 240 to 250 milliseconds on EP studies. When you see this in a young patient or an athlete, this warrants careful further evaluations and to assess the need for an ablative therapy in such a patient. Welling's pattern, which is an impending anterior myocardial infarctions. These are patients that when you are seeing them, they are usually pain-free, but they might have had a previous history or previous episode of a standard chest pain. But by the time you are seeing them, usually they are pain-free. But what we are going to see on the ECG is typically they have the deeply infarcted or the biphasic T wave on V2 to V3 with the minimal elevations of the enzyme. In such a patient, you don't go ahead to do a stress test. What they need in that instance is usually an urgent pulmonary angiography so as to prevent the use of myocardial infarction and sudden cardiac arrest in such a patient. Subsequently, you follow the patient looking at the symptoms and do your serial ECG and troponin to assess the clinical improvement. Now, the other tools that can be used in the risk stratification of patients is our conventional echo. On echo, it can give us an idea about the left ventricular systolic functions. And usually, We assess using our the ejection fractions, which is the strongest independent predictor of sudden cardiac death, and it helps you to determine those patients that are eligible for implantable cardiovascular defibrillators for primary prevention of sudden cardiac death. Anybody that has an ejection fractions of less than 30, it has an increase of sudden cardiac death, though the sensitivity and specificity is low because some patients don't have an induced ejection fraction. However, they are still at increased risk of sudden cardiac death. Now, in such a patient, when you are using echo to do the risk stratifications, you are looking at the age of the patient. The age can give you an idea of what the etiology could be, symptoms, family history, somebody have had a syncope previously. You look at the ECG pattern and the ambulatory data of the patient. The use of cardiac MRI and genetic testing may be relevant to confirm your diagnosis. However, echo alone is not used to decide the need for ICD. These are usually based on symptoms, the use stratification of the patients. All this put together will determine those patients that will require implantable cardiovascular defibrillator. Now, the echo pictures on a patient that has hypertrophic cardiomyopathies, which are high risk marker of sudden cardiac death, and we are seeing a patient that has left ventricular wall thickness of greater than or equal to 30 mm. Ejection fraction is less than 50%. He has left ventricular epicardial aneurysms, and he has an extensive myocardial fibrosis on late ganglion enhancement of more than 50% on cardiac MRI. Or when you see a patient that has a left ventricular outflow tract gradient at rest, the pressure is more than 30 milliliters of mercury. It's always strong predictors of sudden cardiac death in such a patient. In any patient that has a 5-year risk, that is more than 6%. This is a class 1 indication for use of implantable cardiovascular defibrillator in such a patient. For patients with dilated cardiomyopathy, these are patients that has left ventricular ejection fractions of less than or equal to 35%. They are on guideline directed medical therapy. Now, if they are on treatment and they have been on this particular drug for 3 months, you want to reassess them to look at what the ejection fraction like. If the ejection fraction like is still less than or equal to 35%, and they have been optimal on their guideline directed medical therapy, these are the patients that you want to consider for primary prevention of sudden cardiac death using ICDs. Other things that you can use is the global longitudinal strains or the mechanical dispersions, which also assists in the prognostication of such a patient. The right ventricular dysfunction, severe pulmonary prayer also increases the risk of sudden cardiac death in those patients with dilated cardiomyopathy. Now, for patients with hypogenic mitral valve collapse, if you are seeing the patients, those high-risk patients are patients that has mitral annular dysfunctions that is more than or equal to 5 mm. This increases the risk of sudden cardiac death. Systolic coilings of the inferior lateral walls, all this increases the risk of sudden cardiac death in such a patient. Now, for hypogenic right ventricular cardiomyopathy, a patient that has a regional right ventricular akinesia or dyskinesia, a patient that has right ventricular outflow tract on parasanal lung axis that is more than or equal to 35 mm, on parasanal lung axis of greater than or equal to 36 mm. And they have a right ventricular fractional area change of less than 33%. All these are predisposition to risk of sudden cardiac death in such a patient. And these are also correlated and where required further tests with cardiac MRI will be required or genetic testing to assess the risk of sudden cardiac death and the need for an implantable cardiovascular defibrillator in such a patient. Now, for left ventricular non-compactions, the genetic criterion, which is when you have a non-compacted compacted ratio of more than 2 at the end of end systole in affected segment, the risk aligns with the LV dysfunctions and the arrhythmia burden in such a patient. And in stratifying such a patient for an implantable cardiovascular defibrillator, These follow the standard criteria that we use for other patients. Now, for anomalous aortic origin of the coronary arteries, the echo red flags are when there's an abnormal coronary artery curve, as seen on transthoracic echocardiography. The high-risk features that you see in them is the intraatrial or intramural cause. Echo in such a patient raises the suspicions. Coronary angiography helps to define the cause and osteomorphology for a final decision making in such a patient. Now, in reporting the echo for a patient that we are suspecting it could be at risk of sudden cardiac death, these are the particular component that is required. Left ventricular ejection fraction needs to be documented. Maximum wall thickness, the apex for possible aneurysm, the left atrial diameters, left ventricular flood gradient, the mitral phenotypes, the right ventricular outflow diameters, and the coronary origins as visualized should be documented in such a report. Now, the other tools that can be used is the ambulatory Holter ECG, when you are seeing a reduced heart rate variability, or when you have the burdens of premature ventricular complexes of up to 10 per hour, or when you have the short runs of non-sustained ventricular tachycardia, especially in the settings of structural disease. All these are risk factors for sudden cardiac death in a patient. Now, on exercise electrocardiography, a patient that has reduced heart rate recovery during exercise, what is expected that the vagal tone inhibitions is there. There is an increased heart rate, but following the stoppage of exercise, following the reward inhibitory effect, we expect that the rate of the heart rate going back to the baseline should be up to 18 beats per minute. By the time you are seeing a recovery rate of less than 18 beats per minute, it is a poor prognosis in such a patient. Patient whose functional capacity as defined by a MET of less than 5. Patient that has increased ventricular ectopic during exercise and during the recovery period, when you have a short runs of non-sustained ventricular tachycardia in the absence of a structural heart disease. All these are pointed to increases of sudden cardiac death in such a patient. Now, cardiac MRI too plays a very important role in risk assessment of patients. It assists us to quantify the myocardial scar, and this is evidenced by the percentage of fibrosis on the MRI, usually demonstrated by delayed ganglion enhancement, and this has been shown to be associated with increases of sudden cardiac death in such a patient. It could also give us an idea about other causes of structural causes of sudden cardiac death when the test is carried out. Now, the electrophysiology studies are at times required in patients with risk of sudden cardiac death. And these are patients that when you carry out the procedure, when you are having an indistinguishable ventricular tachycardia or ventricular fibrillations, these are patients that probably has the arrhythmias, but are not peak when the ECG has been done. Accessory pathway properties, when you have the shorted PR intervals and the effective refractive periods that are less than 250, all these are pointer to an high-risk property in a patient that has an ancestral pathway. Mechanisms of the arrhythmias can also be confirmed, and these assist us to plan for a catheter ablation therapy or the consideration for a device in such a patient. Now, the choice of therapy in patient that we the choice of therapy in a patient with suspected or want to reduce the risk of causing cardiac death could either be immunotherapy or combination therapy, and this depends on the risk following evaluation of such a patient and the available efficacy and safety of such drugs. Though ICDs is the mainstay of therapy in those patients with an high risk for sudden cardiac death, there are other traditional and non-traditional antiarrhythmic medications that have been shown to benefit, while some does not have any impact on long-term mortality in such a patient. And usually, such a patient, either from cardiomyopathy, non-cardiomyopathy, non-ischemic cardiomyopathy or ischemic cardiomyopathy, usually they are expected to be on guideline-directed medical therapy for patients with heart failure following our conventional medications. For those that has an ischemic cardiomyopathy, they're expected after the initial early perfusion therapy, they should be on dual antiplatelet, statins, and ARBs, as all these have been shown to reduce the risk of sudden cardiac death in those patients. Now, the role of antiarrhythmic medications in the prevention of sudden cardiac death was what was demonstrated in CASH trial, though the study was discontinued. The strategy was stopped because of increased risk of sudden cardiac death post-MI, though it suppresses the burdens of premature ventricular complexes, but at the long run, it predisposes patients to increase the sudden cardiac death because of the pro-arrhythmic natures of the medications. However, in contrast to that, beta blocker therapies have been shown to reduce the risk of arrhythmias and sudden cardiac death in such a patient. Now, the amiodarons, though, will improve symptoms and improve the burdens of premature ventricular complexes. However, it has not been shown to benefit patients in terms of mortality at the long run. And this was demonstrated in the sudden cardiac death heart failure trial, where patient was stratified into those one with conventional heart failure therapy, with placebo, those with conventional heart failure therapy, with amiodaron, and those with conventional heart failure therapy with the use of ICD therapy. At the end of the study, those ones with ICD in conjunction with conventional medical therapy shows to have overall reduction in mortality by 23%, while amiodarons did not show any mortality benefit at the end of the study. This is a typical case that was managed in our center here.
So he's a 52-year-old male being managed for heart failure with reduced ejection fraction of over 2 years, with his left ventricular ejection fraction being 28%. So these are the images of his echo findings.
Now, but what you see additionally on the echo findings is that the patient has on the Doppler, he has a restrictive pattern. If you look at the cardiac chambers, the atriums are dilated, the left ventricles are also dilated, and he has an ejection fraction of less than 30, meeting those criteria for the implantations of ICD to prevent risk of sudden cardiac death. This is an ECG of that patient showing runs of non-sustained ventricular tachycardia. In the cath lab, it also has the runs of ventricular tachycardia. The patient was shocked, and at the end of the procedure, the patient was continuing on the guideline-directed medical therapies together with the ICD implanted, and this is the post-procedure ECG in the patients. Now, looking at the ways of preventing sudden cardiac death in patients using devices, this could be stratified into 3 categories, which will be primary preventions in those ones that have ischemic heart disease, primary preventions of sudden cardiac death in patients with other cardiac diseases, and primary prevention of sudden cardiac death in the general populations. Now, for those ones with ischemic heart disease, now in a patient that has a paramyocardial infarctions, patients are being commenced on guideline-directed medical therapy, probably has had an early perfusion therapy in some instances. But if you such a patient at 3 months if on echo, the ejection fraction is still less than or equal to 35%, and the patient is in near class 2 to 3, 40 days post MI. These are the patients you consider for implantation of ICD to prevent the risk of sudden cardiac death. Now, also, if you have a patient that have had a prior myocardial infarctions, the ejection fraction is less than 30%, is in near functional class 1, and is at least 40 days post MI. It's also an indication for the implantation of ICD device in such a patient. Or a patient who has the left ventricular ejection fraction of less than or equal to 40%, with a non-sustained ventricular tachycardia, and he has an inducible ventricular fibrillation or sustained ventricular tachycardia at the electrophysiological studies. These are patients that requires implantation of ICDs, provided they have a reasonable expectation of survival with a good functional capacity of more than a year. Now, those are the indications in such a patient. In summary, what this slide is trying to tell us is that post-myocardial infarctions, patients 40 days post-MI, you need to reassess their left ventricular functions using echo. If the ejection fraction is still less than or equal to 35 and is still in functional class 2 to 3, these are the patients to consider for ICDs, provided the expectation of survival in them with a good functional capacity is more than a year. Now, for non-ischemic cardiomyopathy, these are the patients that have been on guideline directed medical therapy. And at 3 months of being on guideline directed medical therapy, you are expected to reassess the left ventricular ejection fractions. And if it's still less than or equal to 35%, and the reasonable expectation is more than a year, you also consider is the class 1 recommendation for implantation of ICD device in such a patient, as these have been shown to reduce the risk of sudden cardiac death in such a patient. Though ICD therapy is not indicated in class 4 patients, unless they have other indications like the implantations of left ventricular assisted devices, or patient require coronary revascularization therapy. These are the only reason why you want to implant an ICD in such a patient, because these are patients that have an heart failure that are refractory to conventional medical therapy. Unless if they have all these other indications, ICDs have not been shown to be beneficial in such a patient. For secondary preventions, we consider implantation of ICDs in those patients that have structural disease and they have spontaneous sustained ventricular tachycardia, survivors of cardiac arrest that are suspected is due to ventricular fibrillation or sustained ventricular tachycardia. In the absence of reversible causes, patients that had a cardiac arrest following a myocardial infarctions who are not candidate for complete revascularizations. ICD therapy is also indicated in patients with syncope of undetermined origins who have an inducible sustained ventricular tachycardia or ventricular fibrillation on electrophysiology study. These are the secondary indications for use of ICD as a preventive therapy in the patients that we are seeing in our daily clinics. Now, this is a video of a patient in the cath lab having ventricular tachycardia. Okay, this is a real life patient. Now, there are also reasons to consider ICD device in other non-cardiac or cardiac-related diseases.
And the indications for ICD can actually be divided into the primary and the secondary indications for ICD, and it varies based on the diagnosis. So for people with hypertrophic cardiomyopathies, you can insert an implantable cardioverter defibrillator for primary and secondary protection. And the risk indicators include a previous sudden cardiac arrhythmia or a sustained ventricular tachycardia. That is a secondary indication for ICD implantation. Primary indications may include an adult with greater than or one major risk factor, such as a family history of sudden cardiac death, a left ventricular thickness of greater than or equal to 30 millimeters, syncope suspected to be arrhythmic, or apical aneurysms and ejection fractions greater than or less than 50%.
The other scenario is a patient that has an arrhythmogenic right ventricular cardiomyopathy, in which you want to consider a primary prevention therapy in them if they have up to 3 major criteria based on international task force criteria for diagnosis of right ventricular cardiomyopathy. Or it could also be a secondary indications in which the patient have had a previous sudden cardiac arrest with hemodynamically unstable ventricular tachycardia, or if he has an hemodynamically stable sustained ventricular tachycardia, or a patient that have an unexplained syncope.
Another indication could also be a congenital lung QT syndrome. The secondary indication would include a previous, like I said before, a previous sudden cardiac arrhythmia, and primary indication would be a better ineffective beta blockers, or patients that are not able to tolerate beta blockers. Or when we see a QTC, that's the QT segment greater than 500 millimeters per second on beta blockers. So when you see this, you have to consider these are candidates for primary prevention of sudden cardiac death, and they would need an implantable cardiovascular defibrillator.
Yeah, the other criteria is a Brugada syndrome, in which the primary indications for the prevention of sudden cardiac death in such a patient is when you have a positive electrophysiological studies, or patients for secondary preventions, patients have had a previous cardiac arrest, so somebody that has a sustained ventricular tachycardia, recent history of syncope suspected to be arrhythmic in nature, is a class 1 indications for secondary prevention of sudden cardiac death. Now, the other one is catecholaminergic pulmonary ventricular tachycardia in a patient that have had a previous sudden cardiac arrest. Secondary preventions is the class 1 recommendations, while those ones that had syncope or ventricular tachycardia, while still on beta blockers, or had a family history of premature sudden cardiac arrest, is a class 1 recommendation for primary prevention of sudden cardiac death in such patients.
So the primary prevention of the sudden cardiac death in the general population, that's the overview.
There is no official recommendations as for the role of prophylactic implanted cardiovascular defibrillator as a primary prevention tool in general populations, because the incidence is low, and an attempt to mitigate risk with ICD will rather predispose the general populace to the inherent risk of ICD use, and that's why there have not been a recommendation for the use of implanted cardiovascular defibrillator in the general population, unless there is an indication to use it.
So the recommendations for evaluation of relatives would include familial evaluation of sudden
Arrhythmic death
antecedents is recommended for first-degree relatives, for relatives who must carry a mutation-based analysis of family history, for relatives with suspicious symptoms, and when the descendant's age is less than 50, or if there is any circumstantial data of family history that suggests a heritable disease.
Yes, all these that are mentioned are class 1 recommendations for considerations of ICDs in such a patient. Now, if we have familiar evaluations of sudden cardiac arrhythmic death descendants, is recommended to include genetic testing when the postmortem genetic testing in such descendants has a pathogenic mutations. Now, these are the other class 2 recommendations for the evaluations of relative of sudden cardiac death. And in conclusion,
although the data for many regions in the world is limited due to major public health burdens worldwide, improving our understanding on the risk factors and the underlying conditions and how these can be identified and prevented is necessary to reduce the risk of the societal risk and burden of premature demise from sudden cardiac death.
Additionally, there will be a need for a national data in Nigeria on the epidemiology of the sudden cardiac death in our own terrain. Thank you for listening. Thank you for attending this webinar. We now await questions, clarifications from the audience.